You can know a lot of functional medicine and not necessarily be very capable and confident in using it in clinical practice. Welcome to Functional Medicine for Real-World Impact, where we're diving into the complex, interconnected nature of health and disease, exploring not just theory, but practically what it takes to turn functional medicine insight into powerful, practical, real-world results. So please hit subscribe and let's get started. Hello and good day to you. This is Tracy Harrison from the School of Applied Functional Medicine, and I want to invite you and all progressive healthcare practitioners to come over and join me for a little while today in order to activate and expand your toolbox in helping your patients and clients to not only get well, but stay well. You may be helping individuals with type 2 diabetes or irritable bowel syndrome or asthma or any of a number of autoimmune diseases or long haul COVID, right? So many different things, arthritis, and they may be feeling a little bit better. But as so often happens, they may become stalled in their progress, or they may wrestle with that pesky recurrence of their original disease dynamics. And while there can be many different things at play in driving that, there are also some oh so common pesky reasons that can derail their progress and derail your fulfillment and maybe your confidence as a practitioner. But let's dive in, and I really want to start with the gut, because as we know through the functional medicine lens, so much disease begins in the gut or is exacerbated there. And in particular, IBS, irritable bowel syndrome, is something that is typically not that hard to address through the functional medicine lens, because we're not just putting on a Band-Aid or addressing symptom relief. We actually know how to get at the roots of IBS, the root causes, in a unique individual. And often even good savvy practitioners through the functional medicine lens will use antimicrobials to help counter a dysbiosis, whether it is a pathogenic bacteria or a fungal overgrowth, or maybe an opportunistic overgrowth of a bacteria in the small intestines because of a translocation of that bacteria bolus from the large intestines up into the small intestines, what we often refer to as SIBO, or small intestinal bacterial overgrowth. Any one or multiple of those might be at play in a unique case of IBS. And we can use antimicrobials in order to counter or wipe out that overgrowth. But as we know, unless we address the root causes of why that overgrowth was allowed to happen in the first place, it's just a logical outcome that it's going to recur, because the environment, the terrain in the gut is promoting that overgrowth. So we should expect a recurrence. We shouldn't be surprised by it. And I want to cover with you two things that are often overlooked in cases of IBS. One of them is the presence underneath the overgrowth of maldigestion. Because if we are not well breaking down our food so that we can absorb the nutrients and only leave limited debris from our diet for our microbes to feast on, then we're probably overfeeding our microbial friends. And many more people have maldigestion than often realize it. Normally, it's only diagnosed when it becomes really quite severe, or when it's a consequence of something like overt pancreatic disease. But many of your patients and clients who have IBS are struggling with maldigestion. And in particular, they may have insufficient secretion of digestive enzymes from the pancreas because they have trouble with blood sugar regulation. Now that's an interesting connection, because we're leaving the gut and talking about metabolic regulation and blood sugar control. But research shows that if an individual is struggling with pretty much any stage of pancreatic insufficiency for providing enough insulin to regulate blood sugar, statistically, they are way more likely to also have exocrine pancreatic insufficiency, meaning they're not putting out enough digestive enzymes either. Depending on whether we're talking about type 1 diabetes or preclinical diabetes or entrenched type 2 diabetes, as much as 30, 40, 50% of these patients also have impairment in their ability to digest food because their pancreatic digestive enzyme secretion is suboptimal. And so you want to look for this point of interconnectedness. In some cases, you will find that chronic entrenched IBS naturally improves as people address their insulin resistance and their metabolic dysfunction. And this is a powerful reminder of the interconnectedness in the body and both the exocrine and the endocrine functions of the pancreas. And so we want to be looking for these dynamics. Another often overlooked root cause of IBS recurrence is dysmotility. Individuals, in particular women, can struggle with subclinical hypothyroidism. Subclinical hypothyroidism we see as rampant. And when it is not acknowledged, when it's not being addressed and improved and progressively resolved, then individuals can struggle with recurrent disease like recurrent IBS because there is dysmotility. And when we don't have normal natural peristalsis and the movement of debris through the gut, down through the GI tract, we can cause the buildup of gaseous byproducts from bacteria that can build up and promote dysmotility, further dysmotility in the gut. If individuals have had prior traumatic brain injuries or concussions, or maybe they have neuropathy, we can have autonomic neuropathy, a number of things that might impact the function of the vagus nerve and optimal vagal transmission, which is absolutely essential for regulating pretty much everything in the torso, including the gut and including motility. These are things that can underlie recurrence of IBS. So you want to think about beyond the microbes, right? Or beyond maybe treating the gas with carminative herbs, or treating the flatulence or the dysbiosis with probiotics or antimicrobials. Lots of different interventions that can be effective. But recurrence is common because we're not going upstream far enough in the chain of causality to really get at the roots of that unique person's case of disease. If you've seen this type of complicated dysfunction in your patients or clients when they're struggling with IBS, to really prevent recurrence, we have to address the roots. And another so common reason why they don't get well from so many disease dynamics, but especially from gut-related microbial imbalances or other infections, is because of impaired sleep. And we have an entire bonus mini-clinical course on sleep and why it's so essential and why so many people struggle to sleep. That's available for practitioners, for our public audience. But it's so important that we do a deep dive into sleep and that we don't settle for just the person who says, yeah, I sleep well. You know, I'm fine. Sleep is fine, right? We often refer to fine as being kind of the other F word, right? Because fine is not optimal. Fine is not ideal for supporting health. And there are way too many people who are quick to dismiss their challenges with sleep, where suboptimal sleep, not even overt insomnia, but only sleeping 6 to 7 hours a night instead of 8, maybe sleeping so-so, but sleeping lightly and being easily awakened. We may tolerate those, but what we don't understand is that beneath the surface, that is a source of stress on the body. And you only have to have 1 or 2 nights of poor sleep in order to see data that the next morning, that individual will have a higher primed cortisol stress hormone response, which increases blood sugar, which, by the way, is a great reminder that the aggregate glycemic load of our lives that can become overwhelming and create insulin resistance and eventual metabolic disease. That's not just about our diet. People can have ideal diets. They can eat low glycemic diets and they can be quite physically active and all of these things. But stress alone is a major component of glycemic load in any of our lifestyles. And for some people, the primary impetus for their insulin resistance is not diet at all. It's stress. And stress is unique. People's lives can look very blessed and not very stressful on the outside. But in their head, in the inner recesses of their mind and their self-talk, it is very stressful. There may be a lot of ruminating and worry. There may be a lot of self-judgment and self-criticism. There may be a lot of regret and grief and suffering. Whatever it might be, our nervous system doesn't really care what happy-go-lucky story we're telling our family and our friends. Of course, our nervous system is eavesdropping on the reality of our thoughts, the reality of our beliefs, the reality of our outlook every day, and informing itself based on those inner truths. And when we have a lot of stress, we can suffer. And a lot of this inner stress monologue is also a reason why people don't sleep. But this becomes a perpetuating cycle of disease, because when we don't sleep at length and deeply and consistently, what we often end up with is a progressively higher activated stress state with higher and higher levels of cortisol that are not only affecting our blood sugar, but over time, they're also going to affect our immune system. And I think the impact on immune function that is least acknowledged in communities of practitioners, even in holistic modalities or even in the realm of functional medicine, we don't give enough respect and credence to stress as having a dramatic impact on dysregulating, modulating the balance of our immune system, very often so that we are less able to truly defend against pathogens and fully resolve infections, but yet we become more hypervigilant and reactive. We lose tolerance to elements of our environment that we should be well able to navigate, such as is the case with allergens and hypersensitivities and other related dynamics like asthma. And so stress is a common underlying factor in immune dysregulation that can overtly counter our ability to stop the cycle of IBS, right? If a person has impaired immune function, that is promoting the dysbiosis in their gut, that's promoting IBS, and we're not resolving the poor sleep or resolving the other sources of chronic significant stress, then of course their IBS is only going to temporarily subside and then come back. We'll treat it again. It comes back. We treat it again. We call this the revolving door of dysbiosis, and it's incredibly common amongst practitioners. And you're doing the best you can with the tools and the insights that you might have. But when we know better, we do better. This deeper dive into clinical efficacy, sustainable root cause resolution is the ultimate goal of well-applied functional medicine. And it's what we're really passionate here about here at the School of Applied Functional Medicine. But let me talk more about type 2 diabetes and insulin resistance, because there's some other common factors there as well. I was just doing a Facebook Live for our internal community today, sharing a couple of peer-reviewed published studies over the past several years that have been highlighting some mechanisms at play and some interconnectedness that we well acknowledge in the realm of functional medicine. One of them is that elevated blood sugar suppresses immune function all by itself. This can be a really insidious type of cycle. One of the studies that was really interesting, and is a great read, by the way, is about connecting higher incidence of periodontal disease in patients who have type 2 diabetes, but also higher incidence of type 2 diabetes with people who started with the periodontal disease. And this makes perfect sense, even though we may not necessarily typically associate dental health with metabolic disease. Heck, sometimes we even almost treat the mouth like somehow it's separate from the body, as opposed to being absolutely a critical part of interconnectedness of chronic disease. The mouth is the top of the gut. So often what is happening in the gut downstream has its roots in the mouth, because the microbes, the pro-inflammatory mediators, the waste products, the lipopolysaccharide, we're swallowing so much of that debris. But we also know there can be enhanced permeability in the gums, which can expose the systemic body via the circulatory system to things like increased inflammatory cytokines, higher levels of lipopolysaccharide. This is another reason why you can have hypertension based on what's happening in the mouth. Why dental care is so essential, and why things like alcohol-containing mouthwash, excessive exposure to fluoride, all sorts of chemical beauty products, breath treatment remedies, things that we might use in our mouth can be overtly harming our microbiome, our oral microbiome's ability to thrive and to help support immune regulation. But it's important to realize that even subclinical elevations in blood sugar can be overtly impairing an individual's immune function. Research shows that the mechanisms are quite widespread. Our neutrophils do not degranulate as effectively. Our innate immune system is not as effective when our blood sugar is high. Macrophages are not as effective. We are not able to produce optimal levels of pro-inflammatory cytokines to counter an infection when we have elevated blood sugar. At the same time, we are less able to resolve inflammation once we promote it. And so there's a really fascinating point of interconnectedness here. And then when you have a simmering infectious dynamic, whether it is bacterial overgrowth in the mouth, or maybe a simmering infection in a root canal in the tooth, even further down in the gut, an overgrowth, a simmering overgrowth of H. pylori bacteria in the gastric cavity. Any or all of these that are long-standing can be adding to the body quite a bit of infectious wear and tear from, again, elevated levels of pro-inflammatory cytokines, from elevated levels of lipopolysaccharide and other microbial debris that can actually damage our cell membranes, can promote insulin resistance at the cellular level, that step by step over time can contribute to the development of metabolic disease. So what happens in the mouth doesn't tend to stay in the mouth, and oral health and dental health and care are an essential part of ensuring that individuals systemically are going to be able to sustain improvements in resolving other diseases. Again, whether it's IBS or type 2 diabetes, or autoimmune disease, or asthma. These are important points of interconnectedness. And it's a good segue also to talk a little bit about the importance of expectation setting, right? Again, good, savvy, satisfying clinical work using well-applied functional medicine involves a lot more than science. Yes, we believe in deep, rich, rigorous education at SAFM, and our accreditation, right? Our certification really depends on that. But we've learned it's not enough, because there are lots of practitioners who are very book smart about functional medicine, but they're not very clinically savvy and capable and confident about supporting very richly complex cases that come into their practice. And this is where our education really varies, because this is where we focus. There is an art to well applying functional medicine in clinical practice. Things like setting patient expectations, being able to inspire and motivate progressive lifestyle change. These matter in a big way as to what types of results your patients and clients are going to be able to get in partnership with you in your practice. And the reality is that so often practitioners are celebrating their knowledge. I know a lot, I can assess the case, I can put the puzzle pieces together, I can see the labs, I can see the symptoms, I see all of the data, I've got a great plan and I'm ready to go. But if you haven't cultivated a savvy clinical partnership with the unique patient, where they know, like, and trust you, and where they are galvanized and ready, willing, and able to make lifestyle change on a day-over-day, month-over-month basis, then realistically, your book smart interventional plan, honestly, my friends, is not worth very much. Because if we can't use that plan, if we can't use all those scientific smarts to actually make a difference clinically, then our scientific know-how is not worth very much in the world of transforming lives with elevated healthcare. And I know your heart. We don't go into this work to be book smart and to just collect credentials and know a lot. We want to help people. We want to have those deeply satisfying, fulfilling clinical outcomes, because optimizing outcomes in healthcare is not just about your patient getting well and staying well and being a raving fan of you and your practice. It's also about you as a human being really getting the satisfaction and fulfillment that you crave, that you need in order to keep doing this work. Intervening with and partnering with patients and clients to help address their well-entrenched, complex, multifactorial diseases. It's hard work. It takes focus and care and commitment. And you deserve to do it in a way that delights your patients and clients, but also delights you, brings you a lot of abundance of a full practice and raving fans. And so we have to master the art of clinical application in order to help people to make lifestyle change. And so much of that is about starting where they are and going at a pace that they like. It's so essential to check in with your patients and clients regularly to make sure they love the pace. They may want to work more quickly. They may want to work more slowly. But it's so important to really partner with your patients. You want to work hard, but you don't want to work harder than your patient. What tends to happen is we just overwhelm them, and they may just one day start ghosting you. They're just not going to show up to their appointments. They start canceling their appointments. They walk away. Even when you have tremendous capability, you have tremendous opportunity to give to them. But unless they feel like they can see a way in working with you that they can manage to make step-by-step sustainable lifestyle change, they may simply feel that it's too hard, it's overwhelming, and they're going to walk away. A lot of practitioners fear that they're not giving their patients and clients enough, so they're shoving in more handouts, more education, more videos, more information, more tests, more labs, more supplements, more stuff, in an attempt to feel valuable, in an attempt to try and offer something that will help. And very often, not always, but very often what that leads to is people just being overwhelmed. They feel overwhelmed. They totally give you props. They absolutely respect you, and they believe that you have a lot of capability. But they may walk away from your practice or fail to make good, steady progress in resolving their disease dynamics simply because it's overwhelming to them. So checking in on pace, setting expectations about you offering some interventions and them making some lifestyle changes, and you offering some interventions and them making some changes. And it's a partnership. We oscillate between your strength and their strength and your strength and their strength. This keeps people's skin in their own game about owning the future of their health. It supports them in feeling like they're contributing. They can own their wellness. They can play a major part in moving their away from disease and moving into sustainable health and vitality. So work to create this savvy clinical balance. If your patient becomes disengaged and is looking more for you to fix them, looking more for kind of healthcare to be this external thing that gets done to them, then they may be losing confidence, losing engagement. And that can be a red flag that their results are already stalled or are likely to start stalling soon. I also want to talk a little bit about supplements, because it's a really powerful tool to use through the functional medicine lens. But there are missteps and mistakes we can stumble with in using supplements. And I want to say a word in particular about prescription vitamin D. Here in the U.S., it's a blessing for the fact that over the past decade or so, we've made good strides in the ready availability of prescription supplements, but there are pitfalls to that. And I want to say a few words about the notion of high dose bolus vitamin D, especially when given to someone who has really low vitamin D to start. And this is a great reminder, by the way, that vitamin D is not a typical vitamin. We call it that. It's a misnomer, I think, and can actually be quite misleading, because vitamin D is not a typical nutrient cofactor like vitamin B6 is, for example. Vitamin D is a hormone, and it has tremendous hormonal effects in terms of modulating genetic expression. And just like you would never want to suddenly introduce very large bolus doses of other hormones, whether it's insulin or cortisol or estrogen or testosterone, we best introduce vitamin D low and slow through progressively increased doses that allow the body's receptors to respond, that allow some of the related cofactor nutrients like magnesium and vitamin A to be repleted along the way. Prescription vitamin D in the US today is almost exclusively vitamin D2, which does have some affinity for the vitamin D receptor, but it doesn't result in as much downstream activity as vitamin D3. And so you can fill up a lot of receptors with D2 and create less effective vitamin D response. Is that better than nothing? Sure. But it's missing an opportunity to really optimize the effect of the supplement that you're using. And so we think about really critically important nutrients or supplements, and certainly vitamin D is a concern, and there are people who are truly vitamin D deficient. But there are missteps. Another common one, by the way, is introducing vitamin D in high doses can deplete people's magnesium levels, because magnesium is needed at multiple stages of vitamin D metabolism as a critical cofactor. And if a person already has borderline magnesium status, which a lot of people in your practice do, then suddenly introducing a lot of vitamin D can use up a lot of that magnesium and make it less available. People might then have symptoms from using high dose vitamin D. We might think of that as being vitamin D toxicity, but what it actually is evidence of magnesium depletion. If they start to struggle with more aches and pains, more muscle cramps and spasming, maybe more restless leg, more anxiety, more acid reflux, maybe worsening hypertension, maybe recurring challenges with tachycardia or other effects of excessive stress hormones. These can be mediated with magnesium depletion. So keep this in mind. It's also the case that sometimes they're not getting better behind the scenes in working with you because some medications are in the way. This is where things we may not consider as being overtly disease promoting can be causing major problems, especially when versions of the drug are available over the counter and people may be taking them on a regular basis and they haven't told you. This is a good example of sometimes the questions we don't ask, the deeper dive and inquiry we don't do to learn more case factors can actually be overtly standing in the way of people's progress. So they may be using ibuprofen on a regular basis, maybe daily, just in case, to avoid aches and pains. But as we know, NSAIDs, especially ibuprofen, can be incredibly damaging to the mucosa in the gut. And because, for example, a lot of autoimmune diseases or downstream manifestations of immune dysregulation, like with arthritis, of course, ibuprofen would be an incredibly common drug for people to turn to for the pain relief of arthritis. But so much arthritis begins in the gut, and then if individuals are using ibuprofen on a regular basis for relief, it's continuing to keep the gut lining damaged and perpetuating the terrain that enables the arthritis in the first place. This can be a great example of how arthritis can be perpetuated. The same is true of autoimmune disease, where having good gut barrier function and good rich mucosal support in the gut lining is really essential for keeping immune system regulation. So much of immune regulation in the body depends on functional balances in the gut. But you supported someone in your practice where you went upstream, and you found regular intake of ibuprofen, regular intake of aspirin, right? Of some NSAID that people may not have even remembered to mention to you. They may not even think of it as a drug because you didn't prescribe it, right? They've been told it's safe. So if it's safe to take the maximum amount, surely it's okay to take that every day. And if it were dangerous, wouldn't it be available by prescription only? A lot of perceptions and beliefs that people have that could not be further from the truth. The same thing is true of proton pump inhibitors and purposefully suppressing stomach acid, purposefully creating hypochlorhydria and maldigestion that can overtly impair people's ability to degrade foods and bring on board the nutrients. That can also be in the way. A great example of that I've seen dozens of cases of in the past year alone is individuals who are struggling with brain fog, right? Or different types of peripheral neuropathy secondary to maybe a bad bout with COVID illness. And they're using proton pump inhibitors, and behind the scenes, they already maybe had suboptimal levels of vitamin B12. And then the presence of the proton pump inhibitor is suppressing stomach acid. So it's suppressing the binding of intrinsic factor with vitamin B12 that further down in the intestines supports vitamin B12 absorption. And we need vitamin B12 in particular for the health of the myelin sheath on our neurons in order to support neurotransmission of all kinds, whether that's in the central nervous system or the peripheral nervous system, or for that matter, in the enteric nervous system for supporting motility, as I was talking about earlier. And a proton pump inhibitor that people just think of as an acid reflux med without anybody there to really teach them about the effects, the undesirable effects with ongoing usage of these drugs. This can be a major reason why they don't get well. And this is why it's so important at SAFM for our students to experience case after case after case of real life complex patient scenarios so that you develop not just the scientific knowledge, but the clinical intervention know-how, the wisdom to really find these often hidden reasons why people aren't getting well, or once they get well for a time, why remission is not sustainable, why recurrence happens over and over and over again. A great reminder also, we were talking about stress earlier. We've been talking about hypertension. Another reason why people often don't sleep very well is they have obstructive sleep apnea. This is another thing that shows up literally on a weekly basis in our practitioner forum, with some member of our community having discovered that one of their patients has been struggling likely from sleep apnea for a very long time, and it's a simmering root cause of disease. Because we may think about sleep apnea, not us as practitioners, but your patients may think about sleep apnea as just being pesky, like an advanced form of snoring. And as long as you can tolerate it and get enough sleep and feel okay, it's fine. It's not fine at all. It's acute oxygen deprivation multiple times that necessitates an acute adrenaline surge from your body's perspective to keep us from dying. That is incredibly stressful for the body, and it is a great example of how physiological stress can not only promote insomnia, but can also promote those underlying stress dynamics that are promoting chronic disease. Hidden sleep apnea can be a major reason why people's diurnal cortisol curves are extremely elevated, or maybe if it's been that way for years and years, why their cortisol curves are extremely suppressed. And both of those, a hyperadrenal as well as a hypoadrenal state, can cause dramatic multi-system dysfunction in the body, because cortisol is very much a master hormone and plays a critical role in priming receptor function for every other steroid hormone in the body. It plays a key role in regulating the overall HPATG axis, whereby the brain is regulating the other hormone synthesis and secretion from glands throughout the body. So we want to be looking for these things. Hidden obstructive sleep apnea is a major cause of hypertension. Maybe you've looked at their magnesium levels, their blood sugar levels. You know that toxicity can be a hidden major driver for hypertension, whether it's too much BPA or lead, which is often a issue for late perimenopausal or menopausal women, because the body likes to store lead in bone. And then as you lose progressive bone density at that phase of life, more lead comes out in circulation and can cause dramatic damage to the endothelial lining of our blood vessels, which can impair nitric oxide function, which impairs in particular the arteries' ability to dilate and constrict appropriately and adaptively to our needs, directly contributing to hypertension. But sometimes people are suffering from really entrenched hypertension that just doesn't seem to be responsive to much because of a hidden upstream root cause of physiological stress. And obstructive sleep apnea is certainly a common one. Going back to the mouth, for that matter, there's some interesting research that looks at the impact of using alcohol-containing mouthwash, and the typical chemical-laden mouthwash on a regular basis can have an impact on our nitric oxide function and contribute to hypertension. Again, another great example of how what happens in the mouth doesn't stay in the mouth. These are important points of interconnectedness that practitioners can learn to really master and bring a whole new level of clinical wisdom and true expertise, not just knowledge, not just scientific book smarts, but real savvy clinical wisdom, so that it is galvanizing and fulfilling, not exhausting and overwhelming. So if what I've described today really resonates with you, I want to encourage you, please, to check us out at the School of Applied Functional Medicine. To really reach for a higher potential in your clinical outcomes, not just for your patients, but for you as a practitioner as well. Thank you so much for joining us. Have a great day.